Hi, friends. I'm back again with the third edition or third version of my reminiscences and recollections of certain paradigms which seem to have changed in my last 20 years as an intensivist. Previously, in my last two discussions, I spoke about fluids and ARDS, and I thought loudly about how these paradigms have changed or shifted, if you may call that as it is. I have received fair amount of good feedback, and it has been well received by a lot of my seniors, my teachers. In fact, one of my teachers, my gurus, has actually commented that I am recollecting 20 years in 20 minutes. That itself may be a paradigm change. That means we are probably becoming more and more compact in our meetings, our seminars, and our didactic lectures. But this is anything from a didactic lecture. This is my own thought process, my own understanding, and what I have seen as a transition in the delivery of critical care over the last 20 years. After fluids and ARDS, I thought the most important paradigm shifts or changes have happened in the field of acute kidney injury. It is not anymore the standard to just rely on serum creatinine to define or describe acute kidney injury. In probably 2004, 2005, the rifle criteria came into picture, and we started categorizing patients into those at risk, those who have sustained injury, those whose kidneys are failing, all the way up to those who have end stage kidney disease. This is a very simplistic and probably a little theoretical progression of acute kidney injury. Somewhere along the line, the inadequacies or the lag in the rifle criteria in identifying early AKI was probably noticed, and several other criteria came into the field, like the KIDIGO guidelines, the KIDIGO criteria, the AKIN criteria, the AKIN staging of acute kidney injury, which are more practical and scoreable parameters. While we still have the renal SOFA score to tell us how the kidney injury progresses during the course of somebody's treatment in the intensive care unit, the AKIN and KIDIGO guidelines have probably changed the way we are looking at acute kidney injury. So the paradigm shifts have been in just looking at just one urine output or a creatinine rising value or a percentage rise in the creatinine value, and look at overall picture of what the kidney injury does to the body to define acute kidney injury. So the definition per se, the change in the definition per se of acute kidney injury has been a good paradigm shift or a major paradigm shift. Now, this paradigm shift has also come in tandem with another paradigm shift, that is, understanding that acute kidney injury is a multi system disease. It is no longer a single organ failure when you look at acute kidney injury. We have understood long ago that ARDS and mechanical ventilation for ARDS are also multi system diseases. Cardiogenic shock is a multi system disease. Similarly, acute kidney injury now is also recognized as a multi system disease. Somebody who sustains acute kidney injury will probably have an involvement of other organ systems, overt or occult, which will unmask themselves if the severity of the disease is not handled or the acuity of the problem is not handled very aggressively. So, the recognition that acute kidney injury itself is a multi system disease has been another major paradigm shift. Once we have identified acute kidney injury and we understood the consequences of acute kidney injury, we were again under an impression that early aggressive renal replacement therapy has an advantage in preserving residual renal function and is probably associated with better survival. Nobody was able to define how early is early acute kidney injury. So, when you look at the spectrum of publications which have come in over the last 20 years, initial enthusiasm about early aggressive renal initiation of renal replacement therapy within 12 to 24 hours of onset of AKI found a lot of favor in the first half of the 20 years. Subsequently, we have understood that Early aggressive initiation of renal replacement therapy for soft indications like a fluid overload alone or for other indications other than azotemia, acidosis, and hyperkalemia does not confer any survival benefit among patients who are admitted to the intensive care unit for acute kidney injury. So it is still debatable how early is early aggressive renal replacement therapy. The publications which have described early renal replacement therapy have spoken about initiating it anywhere between 24 to 96 hours. That is a big gap. So, what exactly is early aggressive renal replacement therapy is not yet clear. So, the paradigm shift here is we have gone back to considering initiation of renal replacement therapy for established indications like hyperkalemia and acidosis with hemodynamic compromise and a rising urea and creatinine value rather than initiate it for a very soft indication like a possible positive fluid balance. Similarly, the other aspect which has probably made some change and which has probably has been a paradigm shift is the movement away from feeling or accepting that CRRT is the best mode of renal replacement therapy. Initially, when CRRT came into the picture, we understood and we believed that initiation of renal replacement therapy in a continuous mode is probably better in preserving innate renal function and is probably associated with lesser time in the intensive care unit and earlier liberation from renal replacement therapy. But as we understood, and with the advent of PIRRT, the hybrid forms of renal replacement therapy like prolonged intermittent renal replacement therapy and sustained low efficiency daily dialysis with filtration, we now have understood that it is not the modality which makes the decision or which makes the determination of how soon the patient would recover, but something else which we will talk about a little later. So, CRRT still may have a place to play in intensive care practice in that it has become part of the extracorporeal organ system algorithms like ECOS algorithms or the MOST system, that is the multi-organ support therapy systems. And it is also part of CRRT plus therapies like you initiate somebody on CRRT plus ECMO or CRRT plus plasma exchange or one of these organ support systems. So there, in an attempt to avoid interruption to the process and the multi-system support, CRRT is probably preferred. Still, in some situations like a hepatic failure, for example, CRRT may have a role. But in a general context of an intensive care patient, CRRT probably does not have the glamour and the advantage over other forms of renal replacement therapy which it had about 20 years ago. Then as I said, the paradigm not only has shifted from the timing of RRT and the modality of RRT, but also on the indications for RRT, and we have actually gone back to the more conventional forms of renal replacement therapy. The other paradigm, which I am actually very cognizant about, and I thought I should make a mention here, is about the drug dosing in renal failure. 20 years ago, we followed standard renal drug books and renal recommendations for drug dosing in patients with acute kidney injury. But the fact we have to remember in these patients is that this data of drug dosing in renal failure is essentially drawn from healthy or volunteers who are on maintenance hemodialysis on a regular thrice a week schedule, and based on the PKPD characteristics of those patients, we have been able to get some data about drug dosing in renal failure. But that data cannot be extrapolated into a dynamic situation like an acute kidney injury in the intensive care unit. In fact, some of the patients in the intensive care unit, the younger patients with trauma and burns, for example, have augmented renal clearance. So, that is something we have to understand. And we need to understand that it is not currently correct to extrapolate the CKD drug dosing guidelines to acute kidney injury. Some original work done in 2008, 2006, 2008 regarding the PKPD of antimicrobials in the intensive care unit has helped us categorize these antimicrobials into concentration dependent, time dependent, lipophilic, and hydrophilic groups of antibiotics rather than the conventional classification of aminoglycosides, macrolides, and beta lactam antibiotics. So, this understanding of how a particular class of binding drugs would behave in a patient is then linked to the volume of distribution and its protein binding, which are always altered in a critically ill patient, especially those on extracorporeal circuits. So, in a patient whose fluid balance varies in a 24-hour period, like in a sepsis patient, like a pancreatitis, for example, like a burns, for example, and in a situation where the protein binding can alter because of albumin and its removal, again by the other extracorporeal filters which are applied on these patients, the drug dosing has to be a different ball game among critically ill patients. And as I mentioned before, several forms of hybrid renal replacement therapy are now being applied in the intensive care unit. So you have patients on CRRT, you will have patients on 12 hours of SLED, you may have patients on 6 to 8 hours of SLED. So the drug elimination, the ultrafiltration of some of these drugs which are variably protein bound is variable in these subsets of patients. So even if you label a patient as having AKI, your drug dosing in the intensive care unit has to be based on what exactly is the mode of renal replacement therapy the patient is on and for what duration the extracorporeal blood purification is going on. Based on that, the dosing is actually uh, planned. This has been a paradigm shift. This paradigm shift is probably got to do with the availability of therapeutic drug monitoring. 20 years ago, the only drugs which were therapeutically monitored from an antimicrobial perspective among patients in the intensive care unit were those patients with endocarditis who used to get vancomycin or those patients who were treated with aminoglycosides. We knew that we had to manage these patients with TDM, measuring the trough levels and keeping concentrations above a particular level for vancomycin and probably gentamicin. That's not enough. Currently, the technology is available to measure the peak and trough concentrations of carbapenems. We can measure the peak and trough concentrations of tigecycline. We can measure the peak and trough concentrations of quite a few antifungals as well. So, the advent of this technology and the recognition of this technology has probably made the drug dosing in acute kidney injury a more scientific and a more balanced process than a copybook prescription of CKD patient for the GFR based more than 50, 30 to 50 and less than 30 algorithm to be brought into the intensive care unit. That's another major paradigm shift that has happened in the last 20 years or so. One of the concerns when you put patients on extracorporeal circuits, be it CRRT or ECMO, is anticoagulation. And we have actually tried different forms of regional anticoagulation among those patients who cannot be systemically anticoagulated for various reasons. And critically ill patients present to us with several such situations where you cannot anticoagulate them. So, heparin protamine combination was tried, and we have tried with prostacyclin, and initially we tried with citrate as well. But protamine having its own anticoagulant and anaphylactic tendencies, and prostacyclin being expensive and a cumbersome procedure to do regional anticoagulation with, they did not actually find acceptance in intensive care nephrology as mainstream interventions. Citrate came and went for a few years, except until till a few years ago, regional citrate anticoagulation has been projected and has been made available across the country for patients who are coagulopathic. Whether it really prolongs the filter life and makes an impact on renal recovery is something we do not yet understand. But a paradigm shift is that we now have a tangible option for anticoagulating coagulopathic patients who need renal replacement therapy with a very precious cartridge that needs to be preserved. The most important aspect or an important emerging concept about AKI is the fact that AKI per se is a risk factor for CKD in future. For example, if a non-diabetic young individual enters your ICU with pancreatitis and develops AKI, the pancreatitis resolves and the AKI resolves, and he goes home with a good urine output and a creatinine of less than 1.2. 10 years down the line, this patient has a 3 to 4 fold higher chance of developing CKD on his own without additional risk factors. With additional risk factors like diabetes and other known risk factors for CKD, this risk actually doubles or triples to what it was in the baseline. So, the recognition of AKI as a risk factor for CKD in future has been a major demographic and uh, systematic paradigm shift where we put more attention to early recognition of AKI, and we try to use support the kidneys optimally so that you minimize the risk of prolonged AKI. The longer somebody has AKI, the higher his chances of developing CKD in future. Now, this attempt at identifying early AKI has been again seeing some paradigm shifts, especially in the terms of biomarkers. While technically creatinine, urea, and the urine proteinuria are all biomarkers of kidney injury, they are not actually structural markers, and they probably lag behind by almost 24 hours after the onset of acute kidney injury. And estimation of creatinine again is something that is related to the volume of distribution, so it has some fallacies in its measurement. Some biomarkers became available about 10 years ago, like NGAL, cystatin C, subsequently followed by the kidney injury molecule and the LFAB, but they actually haven't been validated in the broad spectrum critical care population. Certain biomarkers were validated and accepted in cardiac surgery, certain biomarkers in trauma, but never has been a biomarker other than creatinine found to be a predictor, early predictor of acute kidney injury. So the paradigm of identifying the good biomarker, the most reliable biomarker continues. However, now the paradigm shift is bedside availability of renal biomarkers and heart failure biomarkers is become available called the nephrocheck, which will help us to identify some of these patients who may have acute kidney injury. So the use of biomarkers and the identification of early AKI seems to be a major or a significant paradigm shift. Two concepts are worth recollecting here. One is the renal reserve. The renal reserve is something which comes into force and that which actually sustains somebody's stress response to AKI, and that's the reason why some patients end up with AKI, some patients don't end up with AKI, is because of the presence or absence of this renal reserve. And understanding the renal reserve by using a furosemide stress test or doing a renal resistivity index, these are all methods to identify the reserve, and this has been a paradigm shift. So, a patient has been exposed to a contrast or has a risk factor for AKI, assessing his renal reserve will be a good method for determining whether the patient actually will develop AKI in future or not. Lastly, it was always taught to us that hypovolemia begets AKI. But the paradigm shift now is that hypervolemia also begets AKI. If you look at the VEXUS protocol, what the VEXUS is actually assessing is how much of renal venous hypertension has your fluid overload produced. So you are actually assessing the IVC, the hepatic vein, the portal vein, and then the renal vein. So when the pressure on the renal vein is high, the renal venous return is actually reduced, and you end up having acute kidney injury as a result of fluid overload. And that will trigger oliguria, and it will trigger more fluid challenges to these patients. So, understanding that a positive fluid balance is itself a risk factor for AKI, contrary to the belief that it is only hypovolemia that causes AKI, has been a major paradigm shift, and that is something which influences patient outcomes from multiple organs perspective, be it the liver, between the lung, the heart, the brain, as well as the kidney, positive fluid balance probably is uh, a thing which is a paradigm shift. As I said in my first talk, is a paradigm shift, and that applies to AKI as well. So, friends, a lot of paradigm shifts. The definition of AKI, the initiation timing of RRT, the modality of RRT, availability of regional anticoagulation, the advent of biomarkers, therapeutic drug monitoring, recognition of AKI as a risk factor for CKD, and the use of the renal reserves to identify somebody at a higher risk, and of course, renal venous hypertension. These have been some of the paradigm shifts which I have noted. Please do give me the feedback. If you feel I've missed something, please do communicate to me. I'll get back to you with some more thoughts as I keep thinking. Have a good day. Bye bye.